Hey, it's Jessica again. All right, today, guys, we're going to talk about cardiac meds. I know that it can be crazy overwhelming to try and memorize everything. So, of course, I come up with some weird and fun ways to try and remember the meds, the issues, and all that. So, today we're going to talk about cardiac meds. Okay, so first of all, let's talk about positive and negative inotropes and chronotropes. Okay, if you write inotrope down and then chronotrope down, if you take a look at them, which one has HR in it? Well, that would be the chronotrope. So I know HR to me stands for heart rate. So I know that a chronotrope affects your heart rate, and it's either positive or negative. So it either raises it or it lowers it. And then the inotrope does not have the heart rate in it. It doesn't affect the heart. So I just know that the other one is muscular contractions. So it influences your heart either in a positive way or a negative way with the muscular contractions with the inotrope. Okay, and then let's talk about beta blockers. All right, you have one heart and two lungs. So with beta blockers, if you remember the B1 beta blockers, those affect your heart, and the B2s affect your lungs. And some are selective and some are not. So first for beta blockers, those are your olols, metoprolol, like propanolol, those kind of meds, atenolol. Esmolol is the only cardiac med that I know of right now that you can give IV. So the olols are used with heart failure, angina, having an MI, with hypertension. I just remember the beta blockers are the olols, and the B1 is your heart, and the B2 affects your lungs. So you want to be careful with giving beta blockers, because if you give a patient that has CHF, asthma, already has respiratory problems, if you give them a B1 or even a B2 that can affect their lungs, then they can cause them to be more compromised. They could have wheezing, constriction, they can have go into respiratory distress. So you want to be careful about what you are giving with beta blockers to your patient depending on what they do. So what do beta blockers do? Well, if you just have a picture of, think about epinephrine and norepinephrine. Okay, those epinephrine, norepinephrine, each all find their own receptor sites that respond to the epinephrine, norepinephrine. Well, the beta blockers go in their place. So they go in to the receptor sites and they block it so that the epinephrine and norepinephrine can't work. So therefore, by doing that, it decreases the need for oxygen, it decreases the contraction of the myocardium, it slows the conduction down, and it is a negative chronotrope because it's going to lower your heart rate, and it's a negative inotrope because it's going to lower the contractions. And therefore, that will reduce your heart rate and your blood pressure. So if someone has hypertension and they're on this like metoprolol or some kind of beta blocker, it's going to lower their blood pressure and their heart rate. But again, you just have to be careful, because if it works too well, it can lower it enough to where then it's just not functioning. Okay, so before you give beta blockers, you also need to remember if the systolic is less than 110, the blood pressure, you want to check with the doctor and possibly hold the med, because that means probably the blood pressure could be going even lower and it could be working too well. Okay, so adverse effects on your beta blockers. You just want to, some of the beta blockers are non-selective, so they will either go affect your heart or go affect your lungs. So if you're giving them to their heart for their blood pressure and it's non-selective, and it could go and affect other sites like their lungs and cause serious problems. So it can cause like bradycardia, hypotension, heart failure, fatigue. So you want to be careful. Again, make sure that systolic blood pressure is more than 110. You want to be careful with diabetics taking insulin, because it can cause their blood sugars to either go high or low. You want to be careful with asthmatics, because again, it can affect their lungs. And with pregnant women, you want to be really careful there too, because that can cause, if they're on beta blockers, that can cause the baby to have bradycardia and low blood sugars in utero as well. So you want to hold the beta blockers, right? You want to hold them if the blood pressure, the systolic, if it's less than 110, you hold it, but you also want to check the heart rate. So if that apical heart rate is less than 50, you want to hold it and talk to the doctor. Okay? Now let's talk about calcium channel blockers. Okay, if you remember, like from a previous video, I talked about how calcium is the contraction. Calcium makes your heart contract. It kind of amps things up. It gets you all excited. You drink your milk, you're strong, you're ready to go. So with calcium channel blockers, I think calcium cardizem. Okay, I know it sounds kind of weird, but I tried to come up with something to help me remember because the drugs have weird names. So the calcium channel blockers, the drug types are your cardizem, your verapamil, Norvasc, and Cardene. And so those, they use those calcium channel blockers if there's hypertension, if they have angina, if they have VTAC. So with calcium channel blockers, they basically block the calcium so that they won't contract. It dilates the coronary arteries in the myocardium and stops from the heart from doing the extra spasms or the contractions. So if you think you have more calcium, you're going to have more muscle contractions. You're going to be getting thicker and bigger muscles. If you have less calcium, there's less contractions, less force of contractions, and it's going to give your heart a little bit of a break. So the calcium channel blockers will also, it's a negative chronotrope and a negative inotrope again, because you're decreasing the heart rate and you're decreasing the muscular contractions. So your blood pressure is going to go down, your smooth muscle is going to start relaxing some, and you're not going to have to need as much oxygen because your heart's not having to work so hard to pump. So some effects from the calcium channel blockers. So if you think peripheral edema. Okay, if your heart is not contracting as good, the blood is not possibly pumping all the way through the body. I mean, the blood has to go all the way down through your legs, your extremities, and back to the heart. Well, if it's not contracting as good, you could end up getting edema in the periphery or out to your fingers, your ankles, your feet. So you want to watch your patient for that if they're on a calcium channel blocker. It could give them tachycardia, a headache, and it can also cause hypotension. So it could work to the point that it drops the blood pressure low enough that they maybe pass out or their heart rate goes down, anything like that. So you got to really watch that. So you'd want to not just suddenly stop the medication because that could cause some problems, but when your patient is on this, you're going to want to monitor kidney function and liver enzyme levels as well. And then you need to check their pulse daily. And you want them to change position slowly, because if they do end up getting like orthostatic hypotension from it lowering it too much, then they could pass out. Okay, so let's talk about digoxin, okay? My weird saying for this, I don't dig your heart rhythm, okay? So I think about digoxin kind of affects the heart rate. So digoxin, if the patient's apical heart rate is less than 60, you don't want to give it because it's going to lower your heart rate, okay? It's a positive inotrope, so it makes the heart contract more. It makes the heart work harder, but it's a negative chronotrope, so it decreases your heart rate. So they use it for like AFib, AFlutter. Digoxin, this is something you need to know. A therapeutic serum level would be 0.5 to 2 ng. I don't know exactly what that is, ng per mils, but just remember digoxin 0.5 to 2 on that level, okay? With digoxin, some serious side effects. They could have vision disturbances. They can see yellow, green, or blurred vision, and nausea, vomiting. If your patient is nauseated and they're on digoxin, that is your number one sign to check to see if they're toxic, because that is the big sign of toxicity is nausea. Okay, and before giving digoxin, you're going to check a potassium level, because your potassium and your digoxin fight for receptor sites, so in the cells. So if you have a low potassium, there's not as much potassium there to fight the digoxin for the cells. So the digoxin win, they take over, they move in, and all of a sudden there's too much and you can become toxic. So you want to be really careful. So again, you want your patient to make sure you want to check potassium levels, make sure they're eating a diet high in potassium. And again, huge issues if you see that they are nauseated, vomiting, having trouble with their vision. That's the first sign of toxicity. Any level over 2 is toxic, so you want to be really careful with that. Also, have the antidote ready. It's called Digibind, and so that is one of the things you want to watch for. Also, just a helpful hint, you want to watch diuretics also, because diuretics is going to make you pee. You're going to lose your potassium out. So that could possibly make you toxic with digoxin as well. So remember, what digoxin level is toxicity? Anything over 2. And I will continue with cardiac meds on another video. Enjoy.